All right, everybody. Welcome to another Medical Monday. This Monday, we are going to be listening to Toby, and Toby has already done an awesome lecture from last week. This week, he's going to be doing what happens when EMS leaves. So, thank you, Toby, for being here, and take it away.
Absolutely. Welcome, everybody, to Medical Monday. Like Ethan said, today we are talking about what's going to happen once we call the ambulance, what's going to happen after they leave, what's going to happen at the hospital, and what can we do in the meantime. So, without further ado, we're going to talk about it. So, here are the learning objectives for tonight. First thing we're going to discuss is how we can go about gathering critical information for emergency medical services, right? All of the stuff that providers like me are going to want once we get on scene. We're also going to discuss what EMS providers are expected to do on scene, how you can make our job a little bit easier, what you can do to help. We're going to discuss what happens during transport, what occurs once you're in the emergency department, and then possible outcomes after that point, right? So after you're in the emergency department, you're stabilized and you're treated. Are you going to be discharged? Are you going to be admitted? What other care are they going to provide in the hospital? And what's all of that going to look like? So why does all of this matter? Why is it so important for us to understand? Well, calling 911 is truly just the beginning of care. In the lecture that I did last week, we discussed, CPR and AED use, following that check call care process. But really, that call step is just the beginning. Of course, you might be able to provide some life-saving care on scene, but it doesn't just stop there. You're that first link in that chain of survival. Okay. So calling 911 is super important, but it's just the start. Early actions that prepared responders are going to perform are going to improve outcomes. And most importantly, the better that those bystanders and those initial first responders, the better that they work with the EMS crew that's responding, the better care the patient is going to receive. We're also going to discuss the importance of accurate documentation before EMS arrives, because that's going to help them throughout that process, continuing to treat that patient. And the more that we can focus on actually treating them, less so just gathering basic information, the easier that this whole thing is going to be for us. And then this is also important so that we understand the process and it reduces anxiety, right? We're always scared of things that we don't understand. But if we know exactly what to expect once we pick up that phone and we call 911 and we know how the process is going to work, that's going to reduce our fears and we're going to be able to respond so much more effectively. And we usually don't make good decisions on an emergency scene when we're scared. Right? So before we continue, I've got a couple of these sections throughout the lecture tonight that we're going to talk about. I have a question that I'm going to pose to everybody in the group right now. So most of the time, when we're going to call for emergency services and we're going to get a response out to us, we're just calling 911. However, that might not be an option depending on where we're riding. So I would like some ideas, maybe some out of the box ideas, as to how we could request that emergency response if we're maybe in an area without cell service and we can't just call 911 the old fashioned way. What could we do? Anybody, feel free to chime in.
Hi, I'm Mario Lassard. Uh, yeah, having an emergency locator, a beacon, or an emergency locator transmitter.
Yeah, absolutely. That's a great idea. So those emergency transmission beacons, those emergency personal locator beacons, those are GPS devices that basically once we hit the button on the side of them, they put out an emergency call and they give your exact coordinates to emergency responders, and those will locate you via satellite. So those will work pretty much anywhere. These days, they're a little expensive, but they're not too bad. If you have $200 or $300 to spare, that is a great option. And again, it'll work anywhere in the world. Great answer. What else could we consider using? Maybe some lower tech options. Let's say we're riding in a group. Would it be appropriate to send somebody else to go and get help? Absolutely. We can go ahead and do that, right? So if we're out in the middle of nowhere, but we know that 5 miles up the road, there's a place that we could call for emergency services, that's an appropriate answer as well. So there's some technological solutions, some ways that we can get around that issue if we're in a place without typical cell service. And there are some lower tech options as well, right? Just the old fashioned send somebody to get help. That is always an option too. Now, before EMS arrives, right, what is your job? What's the rider supposed to be doing? If you're riding ready, here's what you're going to do. First thing is we have to ensure that the scene is safe, right? We want to ensure that whoever is coming to help us, they're not going to have any immediate hazards when they show up. After that, we are going to provide life-saving care. This could include a couple of things. The first one is emergency moves. There's a variety of ways and a few different reasons why we might need to move an injured rider in an emergency. The most common reasons why we're going to need to move a rider is firstly, in order to do these second two bullet points right here. So if we find a rider that's laying underneath their bike or they're laying in a ditch and they're bleeding severely or they're in cardiac arrest like we talked about last week, we're going to have to move them in order to provide that effective care. Why else might we need to move them? Well, if they're trapped under their bike or they're trapped under a vehicle and that vehicle happens to be on fire, we could try to move them if it's safe for us to enter and do so. Why else might we need to move them? Well, in a lot of situations, if a rider is ejected from their motorcycle, we're going to find them laying on the ground in a prone position. So they're laying on their face. Any injured rider that we find like that, they're not going to be able to breathe in that position. So we're also going to have to move them. There's a variety of different ways in which we could move them safely. Easiest one for you, especially if you're alone, is going to be an extremity drag, right? So you would just come from underneath their shoulders, grab their wrists, and you would drag them backwards with you. So you're both facing the same direction and your back is to the way that you're going. That's the easiest way to move them. If you had multiple other people to help you, of course, you can do the same thing, but somebody else can grab their legs. We can move them that way. All right. Some other life-saving care that we might need to provide besides just moving that injured rider is going to be bleeding control. A lot of the times at these accident scenes, there could be a variety of extremity injuries, chest, neck, head injuries, and they can be bleeding a lot. So we can control that in whatever way we have available. Tourniquet, direct pressure, pressure bandaging, wound packing, just depending on where and what the wound is, we're going to control that bleeding. And then the other life-saving care we might need to provide, like again we talked about last week, is CPR AED use. We might not always have an AED with us, but bare minimum, if we've got a rider in cardiac arrest, we should always be able to do CPR. Okay? So that's our life-saving care. So just to recap real quick, we're ensuring scene safety before EMS arrives. We're providing life-saving care up into our level of training. And then the third bullet point that we want to make sure we hit is giving good information. All right. So this is when we're actually calling 911. We are talking to that dispatcher who is passing along information to our responding crew. This is where the communication between you and emergency services actually starts. First thing they're going to need a location with landmarks, especially if we're out in a rural area or maybe we're off the road. We need to provide a closest address, coordinates, signs, nearby buildings, anything that will help your responders locate you faster. We also want to go ahead and communicate any known hazards, right? So, are there any fluids leaking? Gas, oil, diesel, whatever it might be. We want to call that out and let our responders know. What other known hazards could there be? Well, if there's any utilities involved, right? So if there's electrical lines down and they're still live, we want to pass that information along as well. If anything is on fire, of course, we have to pass that along as well. The other thing we're going to do is pass along number of patients and their condition, right? So do you have one rider that's injured? Do you have 5 riders that are injured? Is it a rider and all of the occupants of a vehicle that they might have been struck by, right? So we're going to communicate the number of patients that we have. That's really important for the dispatcher because we need to know how many ambulances are going to be required. Sometimes an ambulance is able to transport 2 or 3 injured people, but that's not always the case. It depends on where you are. So we want to call out our number of patients and their condition. So if you have one rider that's in cardiac arrest and one rider that's bleeding a lot, we want to make sure that the dispatcher gets that information as well. If you're on scene and you're trying to manage this situation, it can become very chaotic very quickly. So we just want to make sure that anybody trying to provide care on scene is passing all of this information to one person, and we only have one person on the phone with the dispatcher at any given time. Because if you have 5 people calling 911 at the same time, everybody is passing along different stuff. That's going to get confused really fast, and we want to avoid that as much as possible. The other thing that we want to give in terms of this good information is communicating the need for specialty resources. So maybe there's a semi trailer involved that's carrying hazardous materials. Again, something's on fire, or there's electrical involvement and there's power lines that are down. Well, we again want to communicate that stuff and just say what resources we're going to need, right? Is it the utility company? Is it the fire department? Is it a hazmat response? Could be a variety of things. The other consideration that we have here is the need for specialty access. So let's say that we have somebody on scene that is going to require cutting open a car or using the jaws of life in order to get somebody out and start providing care. That is something that we want to communicate to the dispatcher as well. Or let's say that we have gone off road. Now we're 300 yards, 300 meters away from where the ambulance is going to be able to go. We want to make sure the dispatcher knows, hey, we've got somebody in a really weird spot. We're going to need a ton of extra help. We're going to need a way to carry this person out, assuming that they're not able to walk. And then after that, we're following dispatcher instructions. So after all of that is done, we've ensured the scene is safe. We have locked it down the best we can. We've provided life-saving care. We've passed along that good information. We're going to follow the instructions that the dispatcher gives us. Most of the time, if we've already hit those 3 main points, it's just going to be continue doing what you're doing and update me if anything changes. Okay. Before we continue, I'm just going to stop real quick. I'm going to ask if we have any questions. If anybody has questions, please feel free to jump in at any time. All right. Well, it doesn't sound like we have any questions. So we'll keep it going with our gathering information section. So we touched on this a little bit last week, but not too much because most of the injured riders that we were talking about last week. Oh, sorry, you got a question, Marco? Go ahead.
Yeah, sorry, it popped up my mind on the moment that you was
Yeah.
continuing. Maybe I'm not sure in like how far the US is in like the electrification of motorcycles, but we see them here more and more and more on the roads. And it's from a firefighter perspective, like if you call an emergency number, always handy to give like the system that the motorcycle used that is involved in an accident. So fire departments can be preparing certain stuff and certain tools to handle a situation if they get on scene. So that's very valuable information to give to your emergency number if you call. And that was a small addition that I wanted to do, if that's all right.
Yes, absolutely. That is a great point. So for anybody that wants a little clarification, basically what Marco is saying is that if we have an electric bike that's involved in an accident, we want to pass that information along to dispatch as well, specifically because those electric bike or electric car fires are an absolute nightmare for the fire department to put out. They've got those giant lithium ion batteries. They don't go out with just regular water suppression. So they're really difficult fires to control. So that's another specialty resource thing we would want to advise 911 if we're calling them that that is an involvement that we have on scene. Very, very good point, Marco. They're not as popular here yet in the United States, but it is definitely a thing to see.
Oh, oh, hi, I'm Mario. I'd just like to bring another point too.
Sure.
Is that you have to ensure your safety whenever there is uh, a fire with the car batteries or any hazmat spill. You got to make sure that you're upwind. You don't want to be you don't want to cause yourself some injury or anything like this, right? Sometime if
Yeah,
you
great
don't
point.
It's sometimes if you don't know the hazmat too, you don't know what it is, but you got a gut feeling that it's something really really hazardous to your health. Then you got to treat it immediate danger to health, and you got to wait for the people to come and secure the area too. Um,
Absolutely. As a general rule, if there's any potential hazmat involvement, so if anything is leaking, spilled, on fire, or smoking, you want to be upwind and uphill of that incident as much as you possibly can be. And that would be another situation where, as long as it's safe for you to enter and do so, you're probably going to want to move that person you're treating as far away from that as you possibly can so that they're also not exposed. Great point. Absolutely.
yeah. Thank you.
All right. Well, when we're talking about this gathering information, and the next thing we'll talk about is proper documentation. In terms of gathering information, there's some very basic stuff that we want that myself as a pre-hospital provider, when I show up to your accident scene, if you hand me a piece of paper with all of this stuff on it, I am going to love you to death. All right. So here's what we want: a first and a last name of the patient, an age. All right. And then we would also, of course, want to know male or female. And then we would want a date of birth for that patient if you can get it, a current address, and an emergency contact. If at all possible, we want that emergency contact to be an immediate family member. So, legal guardian, mom, dad, if they're adults, adult children, those are all good options. So that is all of the basic demographic information that we want to get about this injured person. All right. Now, the next thing that we want to get are there signs of injury or illness, and then there's symptoms. So remember from last week, signs are what we see, symptoms are what they tell us. So any signs of injury that we notice during our physical assessment, so that's like our quick head to toe trauma exam, we want to write that stuff down. That's information that we want to gather. And then any focused exams that we perform, we want to document the findings of those as well. So let's say that they're still awake and they tell you, hey, my leg hurts, my back hurts, my head hurts. We're going to perform a focused exam on that. We're going to ask them a whole bunch of questions, and that's some other information that we want to gather. The other thing that we want is any information on their allergies. Now, if they're not allergic to anything, that's great. We just want to confirm. If they are allergic to anything, write it down, document it, even if we don't know what it is or what it's for, because they are almost definitely going to get some emergency medications in the ambulance and then probably at the hospital. So we just want to make sure that they're not allergic to whatever they're going to get. And then we also want any information they have on their medication. So this is like prescribed medications they're on and also over-the-counter medications that they take on a regular basis. So some specific items that we're going to be worried about are going to be blood thinners, anticoagulants, stuff like aspirin, anything where if we have a rider that has experienced a traumatic injury, if they're going to be bleeding, we want to know about any medications that are going to make that bleeding worse or more difficult to stop. Okay. We can also ask them some clarifying questions about recent changes in medications that they're taking. Are they taking them the way they're supposed to? This one comes into play a little bit with our medical emergency victims, specifically like those experiencing diabetic emergencies. That's usually where we're going to be dealing with this. And then the next thing that we want to get from them when we're gathering this information is going to be their medical history and any medical conditions that they have, right? So this is all the pertinent stuff: high blood pressure, heart disease, heart attacks previously, strokes, diabetes, whatever it might be. If it sounds important, we're going to gather that information and we're going to write it down. We also want just a general idea of what happened so that when we give a report to our EMS responders later, we can tell them what happened, and we also want to be able to give them a timeline of events. So it might be something like at 7:05, we noticed that they were ejected from their bike and they hit their head against a tree. We found them laying in a ditch on their face. We moved them in an emergency fashion to a safer location. They had a severe injury to their left leg, and we controlled the bleeding. We gathered as much information from them as we could. We had to apply a tourniquet to their left leg. We put it on at 7:15. Here you are. And then this is the information that we got. And then we also want any information on changes in their condition. So let's say, for example, we found this rider in a ditch at 7:05 and they're laying face down and they're awake, they're alert, and they can talk to you. But 10 minutes later, they're noticeably confused and they keep asking you the same questions over and over again, and they don't know what day it is. That's a really important change in their condition that we want to pass along to EMS as soon as they get there. Okay? So I'm going to pose another question to the group. And this one, in terms of gathering information, is going to be how can we gather this stuff from a rider or patient that might be unresponsive? So let's say we just find them in the middle of the roadway. They're not awake, they're not alert, they can't talk to you at all. How could we grab some of this information, do you think?
Per se, if I approach the scene and that the person's unresponsive, I would look for their wallet for their driver's license because it will have their first name, their last name, their date of birth, and the current address that they're at.
Absolutely. That's the easiest way to do it 99% of the time, right? Grab their license, whatever they have in their wallet that's valuable identification, right? So any government issued ID card, student ID card, whatever it might be, we can use that. And they usually, yeah, they have their name, they have their date of birth, they have an address. I've even seen some with an emergency contact on them. So that is a great option. How else could we gather that information? Let's say we open up their pockets, they have a wallet, but no ID.
Some people have like a medical passport in their phone that you can unlock.
Yeah, 100%, right? Some people use that Apple emergency identification feature. I know if you have an iPhone, those will work, right? So when we get on scene, we can grab their information that way. Good
How's
option.
about how's about a registration card?
Yeah,
insurance?
registration card, like from their bike or from their car,
Yeah,
100% we
maybe
can
under
use
the
that.
seat or
Again, that usually has the date of birth on there. At least where we are, it'll usually have the date of birth on there. It'll usually have their full name, and it typically has the address that it's registered to. It might not always be theirs, but it's an address. Yep.
But is it like not dangerous in a way that you are not sure that the license is matching up with the person that's riding the bike? Because if I get a bike of a friend of mine and I'm getting involved in an accident, then the license plate doesn't add up with my credentials anymore.
Yeah, great point. It may not. That definitely would be lower on the list, right? We would say license first, emergency medical ID, then registration. What else could we check? Is there anything else that we could look for? Is there
Yeah.
something that if you're doing a group ride, you could maybe add to everybody's kit to have available to them?
Oh, another thing to maybe you should check the medical alert bracelet about their condition.
Yeah, absolutely. We can check for a medical alert bracelet. Some folks will also have a necklace that basically alerts you to the same thing. Now, that might not always have their name and their date of birth and all that stuff on it, but it should at least tell you what they're allergic to and what their medical conditions are, so you can get some of this information that way. If we're all riding together, oh,
Are you here with us?
sorry, sorry, Ethan, I just crashed for a second.
That's okay.
Let me try to get my screen going again. But actually, since you unmuted yourself, I was going to ask you, correct me if I'm wrong, but if everybody was on a group ride, they can all put their information into the Tag Easy and you could grab their information that way, correct?
Yep. So the Tag Easy system is pretty cool because it comes in the form of a sticker that you can throw on your helmet or on your bike, really anywhere on the back of your phone. Uh, Ideally, somewhere that's not your phone or your ID in case those two things go flying off of you. or there's a card, and I suggest keeping that card away from your wallet or phone as well, so that you have just multiple points of reference. And what's really cool is they scan with a QR code, and we're working on getting NFC here shortly, so you'll be able to just kind of tap with your phone and it'll pull up everything that the person decided to put in. So they can get as little or as most detailed as they'd like. So sometimes you'll find their name, date of birth, allergies, medical conditions that are already pre-existing, a lot of different things, which is cool.
Awesome. And that would cover most of the information that we have to grab from them anyway. So that's perfect. So that is another great option. So again, we can look for their license. We can look for some other form of ID. The other thing that we can do is we can ask bystanders, right? So this might not always be somebody that we know personally. If there's anybody else that they're riding with or they're driving with, we can check those people as well. They probably know who they are. All right. Now, when we're talking about documenting, so we're writing down all of this information after we've gathered it. This is a really important step because we need to plan on, at a minimum, being with this injured person for 3 to 5 minutes. But that could take a lot longer. If you're in the countryside in a more rural area, it might be 30 to 45 minutes before an ambulance actually gets to you. So we don't want to forget any of this stuff, and we want to make sure that when we do pass it along, it's going to be accurate information. So we can write our notes down on paper. We can also do it on our phone. All right, we want to make sure that it is as clear and concise as humanly possible. We also, again, if we have that tag easy available, good way to grab that information. We can also record our times. So some of the important times that we should record is going to be when they went down, if that's applicable to their situation, right? If it's medical, maybe not, but if it's trauma, that's definitely going to be a time that we should grab. Any of their signs and symptoms, so injuries that we found during the physical assessment, and then symptoms they've had. With trauma, it's usually all going to be at the same time. But sometimes if it's medical, like somebody's having a heart attack, maybe they're having chest pain and they've had it for 6 hours. That's an important thing to document as well. We should also document any treatment that we provide on the scene, whether it's bleeding control, medications we're helping them with, even if it's as simple as putting a band aid on a paper cut, we should still document it because at the end of the day, that protects the patient, that protects you, and it's going to become a part of their medical record. So we want to document everything the best that we can. We're also going to save their medication lists and their medical ID info. So if you do, let's say, find a medical alert bracelet on them, you find their driver's license, we're going to keep that with us with the rest of our notes. We're going to pass that along to EMS when they get there. We want that to go from our hand to their hand. That's partially just to make sure that somebody responsible is maintaining control over their stuff at any one time because we don't want to lose it. And again, we're passing along accurate stuff. If they have an insurance, if they have an
Sorry.
insurance card available or something like that, we can pass that along as well. And then if there's any important witness information that might help us or them later down the line, we want to write that stuff down as well. And if there are any important witnesses, we want to get their information too, right? A name, date of birth, address, maybe a phone number so that we can get in contact with them. That's a great thing to have. Not so much for EMS, that's a law enforcement thing. But if you have the time to be able to grab that, everybody on that scene is going to love you. Okay. And then again, just make sure we're only giving this information to EMS providers when they arrive on scene. That's just a patient privacy thing. That's the courteous thing to do. We don't want to be giving out all this information to the crowd that's watching the accident scene.
Hey, Toby.
Now, yes.
Sorry to interrupt. This may just be on my end, but I don't see the screen share. Is that same with you guys as well?
Yes, you're not the only one, Ethan.
Okay.
I don't see
All
it
right.
either.
Try to reboot this. There we go. Nope, not that one. Let's try again. Is that better, Ethan? Can you see it now?
I don't see it.
No, I can see it. It says I'm sharing my screen. That's really weird.
We
Give me 1
may
second.
Yeah.
Let me refresh and hop back in.
Okay. There we go.
We see now. Okay, perfect. All right. So, another question that I've got for the group at large. If we know the basic information that we have to grab from anybody that's going to be going to the hospital, and we know how we should be documenting this, what additional information might we want if this is a head injury, if it's a chest injury, if it's an extremity injury? And I'll let anybody hop in here. Give me some ideas. Let's start with head injury. What additional information might be useful?
We definitely want to let them know if we're seeing any kind of altered mental status, any change in consciousness, anything neurological, really.
Absolutely, right? So we can assess for altered mental status, ask them all of those who, what, where, when, why questions, see if they're confused. We want to check their vision, see if that's normal. We can check their extremities for numbness and tingling, try to assess for that neurological damage. And then if they're walking, or if they're walking when we get there, we can check their balance as well, and that can give us a hint as to if there's any neurological damage going on too. All right, and then we also want to take note of how they're speaking. Right? Are they asking you repeated questions? Are they making sense? And that can give you a hint as to what their mental status is. If it's a chest injury, we can do a focused assessment there. Some other clarifying questions we might want to ask. Are you having trouble breathing? Is it painful when you breathe in? Is it painful when you breathe out? Is it specifically painful in one area, right? And we can take a look at that, at those kinds of things. For extremity injuries, the best thing that we can do is assess and ask them about their circulation, their motion, and their sensation before and after we're going to provide most of the care that we might have to do. Now, of course, if we're applying a tourniquet, we don't want them to bleed out while we're asking them questions. So we're not worried about it then. But if we're applying direct pressure, putting on a pressure bandage, maybe making a splint, or we're just assisting them maybe with resting and icing or something along those lines. We want to make sure that they have good circulation past the injury and the rest of the extremity. So most of the time for that, we can just look at their skin condition, right? So if their injury is to their lower leg, now their foot's turning purple, that tells us that their circulation's impaired. For motion, we just want to see if they can move anything below the injury. And then sensation, we're checking if they can feel anything below the injury. So those are important questions that we want to ask if whatever they have going on is related to an extremity. Now, what's EMS going to do once they arrive? So we have talked about, we've gone through thoroughly what you're doing when you're calling 911, what you're doing on scene. What is EMS going to do on scene? Well, the first thing that they're going to do when they arrive is perform a scene safety assessment, right? So they're going to make sure that the scene is well managed by you. They're going to make sure that traffic is controlled. And they're also going to notify their dispatcher of any known hazards. So again, fluids, fire, electrical hazards, any hostility on scene, any weapons, stuff like that. They're going to call that out. As soon as we've determined that the scene is safe and we've moved where we've needed to, we're going to perform an initial patient assessment. While EMS is doing this, the best thing that you can have ready for them is have the patient in a safe position of comfort. So in a lot of situations, that's just going to be in the shock position. So they're laying down on their back, face up with their legs elevated, or they could be placed in the recovery position. And then we also want to expose any injuries that we found or any significant abnormalities that we found during that physical assessment that you performed on scene. So let's say that they've got a really bad injury that was bleeding to their leg. We control the bleeding. Well, we also want to take their gear or take their clothes off around that injury so that EMS can see what's going on. After they've done all of that, they've performed the patient assessment, they're going to start stabilizing life threats, right? So that's just airway, breathing, circulation, or in some situations, that's the March algorithm. I know that there's a lesson that Ethan did previously on that, right? So depending on what they're going to follow, which system it is, they're going to stabilize any life threats. They're also going to grab vital signs, so heart rate, oxygen saturation, respiratory rate, blood pressure. They might put this person on a cardiac monitor. They might monitor some other vitals as well, like take a temperature or something like that. But they're going to grab all of those baseline vital signs. How can you help out with this? Well, before they get on scene, if you can get a general idea of what their vital signs looked like, that can be a huge help. And it doesn't have to be anything specific. It doesn't even need to be a number. You can just tell them, hey, anytime they try to sit or stand up, they get really dizzy. When we found them, they were breathing really, really fast, or they were breathing really slow, or they were barely breathing at all. Their heartbeat seems really slow, right? Any information like that is super useful. It gives EMS a great idea of what might be going on. And then EMS is also going to gather any additional history or any information that you didn't already get from the patient if they're awake, and from bystanders or witnesses if it's going to be valuable and medically pertinent. Again, the better information gathering that you do on scene, the faster that this is going to go. And of course, if it's a rider that you're with or any member of the public in general, we want to make this step as short as possible because they've got to get to the hospital. Now, what are some of these life-saving treatments that EMS might provide on scene? What should you expect at the scene of an accident? Well, there might be some oxygen therapy, so we could deliver oxygen in a number of ways. Some of them are invasive, some of them are non-invasive. What we have on the screen right here, this is just a simple oxygen mask, so that would be on somebody that needs a little bit of respiratory support, but they're still breathing okay on their own. Airway support, right? So this would be something that we might have to do if they stop breathing, they're not breathing well enough on their own, or if they're in cardiac arrest. And if they are in cardiac arrest, you should expect that we're going to be performing CPR. We're probably going to be using an AED. Now you'll see in this picture here, this is just an example of a cardiac monitor that EMS would carry to the scene. It has all of the same functionalities and a whole lot more than an AED does. But when it comes to working a cardiac arrest, it's basically going to do the same thing. What else should you expect on scene? Well, if there is any bleeding, they're going to be doing bleeding control. Hopefully, though, if I show up on my ambulance, this isn't something that we have to do. This is something that any rider, as long as they're prepared and they have their equipment with them, they can usually take care of this step on their own in the first couple of minutes. Medication administration, if there's any emergency meds that we need to give that injured person, we might do that on scene. Splinting or immobilization. This is another thing that if you're trained in doing so and you're prepared with proper equipment, you can do this pretty easily, and you can even improvise some splinting materials in those first couple of minutes before EMS even arrives. And then they're going to place some monitoring equipment. So you'll notice that everything in here that's within your scope of practice or your level of training as a prepared rider, if you can cut some of these out for EMS, that's going to increase the quality of care overall for that person that's injured, and it's going to decrease the amount of time that they spend on scene. Most important thing to remember here is that at the end of the day, especially if this is a traumatic accident, this person needs to get to a hospital as quickly as possible. All right. We like to say they don't need us on the ambulance. They need bright lights and cold steel, right? That's an operating room. They're probably going to need surgery. So the more that we can take care of in those first couple of basic steps, the better off they're going to be. Now, making transport decisions. When we're talking about EMS deciding where to go and how fast to go, there's a couple of things that they're going to look at. First and foremost, the severity of the patient's condition. Are they critical? Are they unstable? Or are they stable? This is going to tell EMS how quickly we need to package the patient, load them up and go, what hospital we're going to go to, and if there are any additional resources that EMS might need. So they're going to divide the patient, generally speaking, into one of three categories: critical, unstable, or stable. Quick breakdown on those. A critical patient basically just means that this person is already dead or they are actively dying. So that's cardiac arrest, not breathing on their own, barely breathing on their own, lost most of their blood volume. That is a critical patient. An unstable patient is somebody who's not actively dying, but they're pretty close. We usually make that determination based off of somebody who's experiencing a life threatening emergency, but we're able to stabilize them on scene. And then a stable patient is somebody whose vital signs are good to go, their mental status is good to go, and usually they can move around by themselves, they can talk to you at least a little bit. That patient would be stable. All right. So again, not all patients may require immediate transport. So that decision is going to be based on their overall severity. The other thing that EMS is going to have to consider is where is this person going to go? Now, in the United States, the patient ultimately has the choice of what hospital they go to, but that only applies if they are awake. So if this person is unresponsive, they can't make that decision for themselves, EMS is going to take them to the closest, most appropriate facility. So if this is a traumatic accident scene, that's usually going to be the most capable trauma center in the area. The important thing to understand with that is that that hospital might be quite a ways away, depending on your area, right? So I can tell you that for me, where we are in Buffalo, we have a level 1 trauma center that is well capable of handling any patient from any traumatic emergency scene. However, if you're out in the middle of nowhere, it might take you 45 minutes to an hour in order to get to that trauma center. And there's only a couple of them in the state. So that's something to consider as well. It might be an extended transport time, right? And then with that transport, you should also know the difference between an emergency transport and a non-emergency transport. All of that means is that during an emergency transport, EMS is going to drive as quickly as possible while maintaining their own safety and the safety of the patient. So it's probably going to be lights and sirens, cutting through traffic as much as possible to save time. Marco, it looked like you had your hand up. You had a question?
Yeah, that's right. I was wondering what is the difference between a critical access hospital and, for example, a trauma center, because all the hospitals that we have here, like in the Netherlands, are like really the same. So they handle all kind of traumas and specialties, and so I was wondering
Yeah.
what the difference is like in the US with that.
Yeah, great question. Great question. So in the US, unfortunately, not all hospitals are the same. Wherever you go, they're very, very different. Like our patient conditions, these can kind of be broken down into 3 categories. We have critical access hospitals, we have general hospitals, and then we have trauma centers. There are other specialty types of hospitals, but when we're talking about trauma patients, these are the 3 that we're going to be dealing with. A critical access hospital essentially means that they have beds, um, and they have doctors, they have nurses, they can provide you with medical care, but they can't do much other than that. So they're not going to be able to provide real stabilization for a patient that has experienced a traumatic injury. And at some point, very quickly, after you've gone to a critical access hospital, they're going to have to send that patient to a higher level of care, right? So they would have to send them to a trauma hospital because that critical access hospital is missing a couple of critical items: surgery, labs, and imaging. Most critical access hospitals are missing one or all of those things. A general hospital is a place that can do most of those under general circumstances. So they have the ability to do advanced imaging, they can do surgery, and they can do labs. So most of the stuff that you would expect a hospital to do, but they don't have a trauma team. So they don't have that specialized care specifically for traumatic emergencies that's going to be able to provide that surgery and follow up that that patient requires. A trauma center has all of that stuff in place, right? They have the surgery, they have the imaging, they have the special teams, they might have a burn unit, right? They can deal with all of the stuff that you could possibly imagine. Now, that is just a very broad overview. In the US, there's also 4 different types of trauma centers. So you have level 1 through 4. and each one of those designations tells you exactly what they can do. So, for example, a level 1 trauma center can do absolutely anything you could possibly need for a trauma patient. They also have the ability to do invasive emergency trauma surgery, and most importantly, they have a 24/7 team that is always available on standby in the facility.
Thank you. That's a clear explanation.
Yeah,
Can I add something
absolutely.
to that too?
100%.
And also, like a trauma level 1 facility has the means to care for that patient even after the trauma event. So whether that be like cardiopulmonary machines, ECMO, all these different extremely advanced systems that you'll only find at a level 1 facility to take care of that trauma patient after the event.
Exactly. So they have all of that important life support apparatus to care for them. And once you reach that destination, they're not going to leave there. There's nowhere else to be transferred to. That is your highest level of care. Absolutely. Good point. So those are the types of hospitals we're going to be dealing with. Going back to that mode of transport, again, emergency versus non-emergency. Emergency transport, that's going to be for your critical and some of your unstable patients. Not all of them. That is dependent on the EMS provider. It is at their discretion because, of course, we want to keep everybody safe. So they're going to take into account things like, flow of traffic, traffic density, distance, and that kind of thing. And then your non-emergency transport is basically just for your stable patients. No lights, no sirens, driving the speed limit with the normal flow of traffic. Now, one thing that I also want everybody to consider, especially let's say we're doing a group ride, we have a bunch of people, somebody's injured, is EMS going to allow other people to ride in the ambulance? And truly, there's no one size fits all answer for this. Some EMS services say, yep, you can come in the ambulance as long as we have space. Some EMS services say you cannot ride with this patient unless they are younger than 18 and you are their parent or guardian. So it entirely depends. The best thing that you can do as the patient or as a friend who's providing care on that emergency scene is ask EMS and just be prepared for a variety of responses. So don't just assume that you're going to be allowed in the ambulance, no problem, hop in and you're good to go. Just make sure you ask before you do anything on the scene. Now, what is EMS going to do en route? So we have left the scene of the emergency. We're en route to the hospital, regardless of what type of hospital that is. A couple of things they're going to do on the way. They're going to continuously monitor those vital signs. Now, circling back for a minute, for those critical type patients, those are going to be reassessed every 2 minutes. So literally every 2 minutes, we're going back and we're checking heart rate, blood pressure, respiratory rate, oxygen saturation, and all of that wonderful stuff. For those unstable patients, we're going to be reassessing those vital signs every 5 minutes. And then for those stable patients, mental status is fine, vital signs were fine when we checked them last. They're usually going to get reassessed every 15 minutes. There's also going to be some ongoing treatments and reassessments that are performed. Okay, so what you should expect in the ambulance is that there might be IVs started, there might be medications administered, there might be bandages applied, and that patient is probably going to be exposed. So at this point, all of the gear is going to come off of them. Their clothes are going to come off. We get them what we like to call trauma naked and ready for the emergency department. Because our trauma centers around here, they do not like their patients delivered with clothes on. So we're going to have to get all of that off in order to do a complete and accurate physical assessment. And then after all of that's done, patient's taken care of and they're stabilized as best as possible, there's going to be some communication with the receiving hospital, right? Especially if this patient is going to require that advanced level of care and we're going to a trauma center. That trauma team wants to know that that patient is coming because they might need a dozen different people in place ready to receive this injured person. Right? And then they're also going to document the care that they provided. Now, some EMS providers will do that right there in the ambulance. Some will wait until after the call is over and care is transferred. It just depends, but usually there's going to be some form of documentation performed electronically in the ambulance. Now, for this communication with the hospital, basic stuff that EMS is always going to pass along. Patient condition first, right? So we're going to say, hey, we've got a critical patient, we've got an unstable patient, we've got a stable patient. This is what happened to them, right? So maybe, hey, we've got a critical patient coming to you. They're in cardiac arrest. We're in the middle of doing CPR, and we found them however long ago, right? In that condition. Then we're going to talk about the treatments that were given, right? So it could be CPR, medications administered, tourniquets applied, bandages applied, whatever it might be. And then an estimated arrival time, right? So are we going to be there in 2 minutes, 20 minutes, 2 hours, however long it's going to take to get to that hospital? And then any special needs that we immediately know that patient is going to need. EMS is going to pass that along as well. Trauma team, stroke team, heart attack team, whatever is appropriate for them. And it could be multiple teams at the same time. That is definitely a possibility as well. Now, after that transport's over, they have arrived to the emergency department. What's going to happen in the ER? Well, EMS is going to transfer the patient to emergency department staff. They're going to get a verbal report from emergency medical services, which is basically going to sound exactly like that report they got on the radio. We just might have some clarifying questions at this point, because of course, if that report was initially over the radio, we don't want to tie that up. We don't want to take too long. Now, once we're in the ED, if anybody has clarifying questions, that's when that's going to get sorted out. There can also be a transfer of written or electronic documentation. So in a lot of emergency departments, as soon as the patient gets there with the ambulance, that EMT or paramedic, they're going to ask that receiving facility to sign for the patient like a FedEx package. It's just verifying that they were actually received at this date and time. This is the condition that they were left in. And then they are going to be moved to an appropriate treatment area. Most hospitals, especially trauma centers, they always keep rooms and beds available for patients like this that are coming in on very short notice, right? So usually, if that patient is severe enough, they're not going to be hung up with that report for a very long time. That report's probably going to be given while we're in the middle of moving to a bed. And while we're giving that report, people are going to be putting hands on them, getting monitors attached, starting IVs, and they're going to begin providing care and getting ready to do everything that they need to do for this patient. If you're sitting there and nobody's moving you yet, that's actually a good thing, right, for that patient. That means that they're not severe enough to warrant that immediate care right then and there and movement to a trauma room. That's actually a good thing. Right? Now, some other stuff that's going to happen in the emergency department. A triage assessment basically just says, how severe is this patient right now? And then what kind of resources are we going to have to dedicate to them? So that's very similar: critical, unstable, or stable. They're going to base their decision off of that. They are going to perform some vital signs assessment and continuous monitoring. So somebody's probably going to hook that person up to a monitor, and that usually will go back to a centralized nurses station. So somebody's always sitting over there who can watch what's going on in real time with their vital signs, and they can get reassessed every 2, 5, 15 minutes, or at longer intervals if the doctor determines that that is acceptable. And then there's going to be a physician or advanced provider evaluation, right? So this person's going to see a doctor, and then the doctor is going to determine what is their course of treatment going to look like from here. What kind of tests do we need? Are we going to refer them to a specialist and that kind of thing? And then there might be some diagnostic tests, right? So there could be labs, imaging like CT scans and MRIs. An ECG is just a picture of somebody's heart. And in a lot of cases with a trauma patient, just to cover all of the bases, they're probably going to get all of that stuff, and they're going to get it very quickly. All right, now, one of the last things that I wanted to talk about is if you're in a situation where all of this applies to you directly and you are the injured rider, what are some things that you can do to be a good patient so that everybody you interact with is very happy with you and you get really good, nice, kind treatment? First thing that you can do makes everybody's life easier, from basic bystander to doctor in the ER. Have your personal medical information updated regularly and readily accessible in an emergency, right? So using that tag easy is definitely the easiest way to do that. Just make sure that you have your medication your allergies, your medical history, all in there, ready to go, as well as your demographics, name, date of birth, all of that stuff. Make sure you designate a responsible emergency contact. Responsible means that somebody you're comfortable with making life-saving decisions for you, right? So if you wouldn't want them next to you while you're in that hospital bed, they're not a responsible emergency contact. They also have to be an adult. And then understand the triage process, right? So some emergencies, a lot of the ones we've been talking about, they are immediately life-threatening, but that doesn't apply to everything that might occur. So just understand how the triage process works, right? If you're a critical patient, you're going to be seen the fastest. If you're unstable, you're definitely going to get seen quickly, but it might not be right away. And then a stable patient is probably going to have to be waiting a while. Make sure that you communicate clearly and honestly with every provider that sees you, right? Try to keep your story straight, right? Make sure that you give all of the same important information to everybody that asks you. And then just be patient and understanding, right? It's hard to lose sight sometimes as that person that's being treated that everybody caring for you is human too, right? So just be as nice to them as you can, be understanding, be patient, and you should be good to go. Now, after all of that's done, what else are they going to get in the ED or in the hospital? Well, they might get some IV fluids or medications. There might be some advanced airway management if they're not breathing well on their own. If it's trauma, there's always going to be a surgery consultation, right? So that might be to repair injured blood vessels, to repair fractures. They might have a neurological injury that requires some surgery. There could also be some specialist evaluations. So that could be from a surgeon, an internal medicine specialist, a radiologist, any type of specialist could be involved. And then there's going to be continued observation the entire time, right? As long as you're in the hospital, they can't just leave you alone. Now, some hospital outcomes that we might be looking at. Somebody can be discharged home. They can be admitted to the hospital, which means that they're staying, and they're typically going to be transferred, if they're admitted, from the emergency department after they're stabilized up into the hospital to another floor, to another room that's a little bit more comfortable than an emergency room. They could also be transferred to another facility. So that's kind of like our third option, which is basically they can't stay in the ED, and this most commonly happens when that critical access or general hospital does not have that level of specialty trauma care that the patient requires. They're going to be sent to another facility. They could also be sent to another facility if they have to be admitted, but there's no space in that hospital that they originally went to. That can happen as well. If they're transferred to another facility, that's basically just a second ambulance ride, right? So if we just circle back to what happens en route to a hospital, it's the same thing. EMS picks that person up just like they would from the scene of an accident. They transfer them to that new hospital. They go through the emergency room. Very, very similar process. They could also be placed in an observation status, which just says they're okay right now, but we should keep an eye on them for a while. They're going to stay in the emergency department, maybe overnight, maybe for a few hours. It's going to depend on their condition, but they're just hanging out in the ER, and we're going to watch them. Now, if a patient is discharged from the emergency department, what can you expect, right? If you're still with the patient or you are the patient yourself, there should always be instructions for home care. So if you're injured or there's an illness going on, they're going to tell you, hey, here's what you can do at home in order to not make this worse. What prescriptions are you going to have to pick up from the pharmacy if you have to, right? Sometimes they can give you the medications there, but a lot of the times you're going to have to go and pick them up. They're also going to give you follow-up recommendations, right? So for a lot of traumatic injuries, after you're discharged from the hospital, they might refer you to a physical therapist or a recovery specialist, and that would be your follow-up care. They're also going to tell you warning signs to watch for, which basically means, hey, if you're home and you start experiencing this, or this, call 911 and come back to the hospital right away. And usually they're going to give you all of this stuff in a nice little packet that they're going to send you home with. And a lot of places nowadays, they'll give you that packet, but everybody seems to lose it. So they typically have an online version that you can pull up as well. And all of that stuff becomes a part of that patient's permanent medical record. If, on the other hand, instead of being sent home, they get admitted to the hospital, they could be transferred to an inpatient unit. So we would usually call this like a medical, surgical, or an observation floor. So they're not critical, they just have to stay in the hospital. Or they could be transferred to the ICU or intensive care unit. For a lot of trauma patients, this is going to be their ending destination at the hospital because there's so much going on with them that they need care from nurses that are specially trained. They're going to have ongoing monitoring and treatment, regardless of where they go, that is going to apply. They might have some specialist care. So again, neurologists, radiologists, surgeons, they could have possible procedures or surgery. And then their length of stay is going to vary by their condition. Somebody could be admitted to the hospital and just stay overnight. Somebody could stay for a couple of days, a week, or they could be there for months. It just depends on what happened at that scene of the accident. All right. So key takeaways before we go through our Q&A. Just make sure, again, the best thing that you can do is ensure that you're riding ready at all times, right? We went through those 4 major components of that chain, which starts with you on scene, EMS once they get there, EMS during transport, and then care at the hospital. By far the most important is that first link, right? It's you when you show up as that prepared rider. So make sure that you're ready to go, you have your equipment, and you're trained up, and you can respond properly. Have a way to contact emergency services regardless of your environment, like we talked about at the beginning. Sometimes your phone's going to work, sometimes it's not. You should have a backup plan at all times. Take standard precautions on emergency scenes. Train to provide the best care that you possibly can. So make sure you're keeping yourself safe. You should carry gloves with you, right? That PPE, maybe a face shield for doing CPR, just so you're ready to go and you don't have to put yourself in an unnecessarily unsafe situation. And get trained, right? Because we can't expect you to do all of this if you've never had hands-on practice. So you want to make sure you can get that. Always document your findings on that emergency scene and care you provide to the fullest extent possible. And then assist EMS on scene. Be ready to assist with follow-up in and after the hospital, right? So some of that will apply if this is a friend of yours. Of course, if it's not, it's just a member of public. Be prepared to assist them on scene when EMS is there. And then that's when your care is going to end. All right. So I will stop here for a few minutes for questions. Anything at all related to this topic or something else medical, please, anybody feel free, jump in. As you probably know at this point, I love answering questions. So whatever you got, throw it at me.
So a couple of years ago, I ended up at the hospital for gallbladder surgery because I had gallstones. It was very painful.
Yes, it usually is.
My dad drove me, but per se, if my dad didn't drive me and I did call an ambulance, my symptoms were pain that starts in my lower back, radiating into my lower right abdomen and into my chest, nausea and constant vomiting. What would I be considered? Would I be considered a stable patient or any of the others?
Great question. So we would look at a couple of things for determining what category you fall into. Now, if you're awake and you're alert and you can tell the ambulance crew what's going on, that automatically cuts out the critical step, right? You're not critical. So that's good news. Then we have unstable and we have stable. If when you get in the ambulance or in your house when you're being assessed, if your mental status is good and your vital signs are within normal limits, so what we would expect them to be for your age, weight, and gender, then you would be stable. If any of those are off and they're off enough to make us concerned, you would be considered unstable. Okay. So I'll give you an example. If we'd show up on the scene, you complain of pain, you're really confused, your blood pressure looks like you're about to pass out, and you have 10 out of 10 pain, you would be unstable. But if we show up, you're awake, you're alert, you're talking, you can walk, your vital signs are good, and you're just in 5 out of 10 pain, you would be a stable patient.
Okay, thank you.
Yeah, of course. Good question.
I have a question too, but it's more like out of own interest in a way. Like if a patient is coming to an ER room, I see almost on television almost of the time that there are a lot of doctors, a lot of specialists running around talking with each other. For me, it's one big organized mess. But how
Yes.
track in like who is what doing, and that that is something that I wonder.
Like, how do they keep track of their own patients?
Yeah, because for me, like as someone is that is not working like EMS or something, is they're running around all the time.
Yeah, and to be honest with you, Marco, that is an accurate observation. That's pretty much what they're doing. I can tell you that in most U.S. hospitals, your specialty providers and your doctors, especially in the emergency departments, there might be one doctor in an emergency department with 15 patients, right? It's not always that many. Sometimes it's less, sometimes it's more, but that is definitely a thing. So in that case, it's very difficult to kind of control the chaos. So usually what that means is the doctor is going to spend a lot of time documenting in order to make sure they don't miss anything. But unfortunately, the more patients and the more running around they're doing, the way that they actually manage that is by spending less time with each patient. So that's why sometimes if anybody's had the experience of going to the emergency department and the doctor kind of blows you off and they only spend 3 minutes talking to you, that's probably because that doctor has so many patients that they don't have any more time to spend with you. So that's kind of how they figure it out and they organize the process. But yes, usually
Yeah,
it looks very messy.
yeah, indeed. Yeah, it's mostly what I mean. Maybe I explained it wrong. Is like if a patient is coming in, like from an ambulance or an helicopter, and everyone is focused on one patient. You have a lot of specialties like around the bed of one person, but you see a lot of doctors at the same place working on the same patient.
Like, how does everybody figure out what they're going to do?
Yeah,
Is that what you're asking?
because you have
Okay.
maybe 20 doctors for one patient. Maybe one is for the X-rays and scans, and it's like, how do I explain it right? It's for me, it's one
Yes,
big mess around
I
one
see
bed.
what you're asking. So you're saying we roll in with a trauma patient. How do the 20 people that are going to care for that patient know what everybody else is doing, right?
Yes, indeed.
Okay. There's three ways that they get around that. The first one is previous training and a lot of training. So I can tell you that at a trauma center, those are drills that those nurses and doctors are going to perform and they're going to practice together while they're working on a pretty regular basis. So it's something that they practice. Secondly, it really comes down to communicating effectively with the limited space that you have, right? So everybody should know what everybody else is doing. So if you've ever had the opportunity, it sounds like you have, of watching those 20 nurses and doctors around that one patient, you probably see and you can hear that everybody is really close, but even though they're really close, they're speaking very loudly. They're constantly giving orders. And anytime somebody says something to another provider, they're usually going to repeat it back to them. We call that closed loop communication. So, like if I asked you, hey, go grab me this medication, you're going to repeat that order back to me exactly as you heard it. So that way we don't miss everything and everything gets covered very, very quickly. And then the last thing that they're going to do is they're going to lean into their specialty. So everybody before they walk in that room, they have a job and they know what their job is. So let's say we're doing CPR. Nurse one is going to be doing compressions. Nurse two is going to be ready to perform compressions after nurse one is done. Nurse three is going to be administering medications. Nurse four is going to be defibrillating. and then doctor number one is going to be standing in the corner leading the entire thing. So everybody has a job before they even walk into that
And
Awesome. Thank you.
I can throw a little bit of extra info into that too, if you want.
room. Yeah, absolutely.
Since the hospital is my realm and I've done it a lot. So another thing to add to that too is, like, you may be wondering how those roles are decided, or who's nurse number one, who's nurse number two, and that goes back to like ACLS, which is where it's an algorithm and a way that nurses and doctors are taught to organize a scene, before the casualty or the trauma victim arrives, is that we have all decided on what everyone's going to do, and the person who chooses those roles is usually the primary nurse or whoever's going to be in charge of that patient. One thing that's interesting is, for every patient there always is a primary nurse, so that patient does belong to one nurse and one doctor or two doctors. In the I'd say the highest level trauma center that I was in, was usually at a minimum two doctors, 4 or 5 nurses, a whole respiratory team. You have a lab team. You have, like you said, 20 different people who are all pitching in to help. And another thing too is, kind of like Toby was saying, is that this has all been rehearsed. Usually, nurses will they'll choose to do the assignment that they're best at, or that they have been doing repeatedly. So, one nurse who's really good at access and good at getting IVs laid, they're going to probably be doing that. The nurse who's really good at cutting clothes off and getting them trauma naked, that's going to be another job. And then, whatever your job is. Oh, another one that's really good is a rapid transfuser, or like doing the blood. Usually, the nurse who's really experienced at transfusing blood is going to be the blood nurse. And so everyone has their role that they're good at, and it all comes down to communication. So before they come in, we all kind of get together in the trauma team. All right, who's doing what? And yeah.
Yeah, absolutely. And just to piggyback off that, Ethan, speaking of that, like advanced life support algorithm and training, we teach, that's a course that we teach all the time, to all different providers in all different settings. So that can be combat medics, street medics, nurses, doctors, whoever it may be. But everybody follows algorithms that look like this, right? So it basically gives you a flow chart for that team to follow based on the patient's condition. And we have these for everything that you could possibly think of, from the most simple stuff to the most advanced stuff. So this also makes the process a little bit more controlled. Any other questions?
Hello?
Yep, I can hear you.
Okay. Uh, there's one thing we haven't touched is what should you uh, the person, the patient uh, on the scene. Sometimes you could have some personal effect, right? So what should you say he's got a phone or something like that? I guess it's got to be taken with him, right? We will give it to the crew, I guess. So
Yeah,
what
great
happened?
question.
What happened with
Yeah,
the rest
so
of?
um, any personal effects like that, whether it's a phone, a wallet, a backpack, the best thing that you can do if you know that it belongs to the patient, if they're awake and they're talking, leave it with them, right? Give it to them. Or if they're not, give it to that EMS crew, all right? If they're really confused, give it to that EMS crew, because they're probably not going to be able to hold on to it and they're going to lose it. We don't want it to get lost. So, yes, if they're awake and they can hang on to it, leave it with them. Otherwise, give it to the ambulance. Great question.
Okay, so I guess, or you could ask them what they want to have, right? Like if they say, "Oh, could you bring me this or that?" and If they,
Yeah,
if
right. Do you want your phone? Do you want your wallet? That kind of thing.
yeah, yeah, yeah,
Now there are some personal effects that are not realistically transportable in an
yeah,
ambulance, especially during an emergency. So I'll give you an example. Let's say that there's a rider involved in an accident with a car, and the person driving a car uses a wheelchair to get around.
yeah.
We're not going to be able to take the wheelchair in the ambulance, so if we can, if there's anybody else with them, we would want to make sure that they have somebody responsible that can take their wheelchair for them to the hospital later, or they can take it to their home.
Okay, I just have a question. It might be a bit outside the subject, but so what
Sure.
happened to the motorcycle and all the stuff? Usually, 911 will call the police will take care of that and call somebody else, or I'm just a little curious. Like this,
Yeah, good question. With the damaged motorcycle, typically that is going to be a law enforcement thing. I can tell you that everywhere in the United States, with the damage, EMS might want to look at it, but they're not going to do anything with the motorcycle, right? They're not going to move it because they don't want to disturb any evidence that might be there. They don't want to uh, they don't want to damage the investigation, and then law enforcement at some point they're going to remove the bike. If it's damaged, it's usually going to be towed to a yard, like for damaged vehicles, or it's going
yeah.
to go to the police lot that they have.
Okay, so I should stay on the site until the police is there, and when they're there and the patient's taken care of, then I can leave, right?
Yeah, if you're not going to go with the patient, yeah, you should stay as long as you're able to. And usually, once law enforcement has taken care of the bike, the patient is on the way to the hospital. Unless you're going to go to the hospital with them and it's somebody that you know, law enforcement or EMS will usually tell you, hey, you're all set. Thank you for your help. You can leave. If you're sitting there for a long time and you're like, man, I kind of got to leave, and nobody's told you anything, just ask, right? Whoever looks like they're in charge, whether it's a paramedic, a police officer, just say, hey, I was here, I helped with this, and I did this. Do you want my contact information? Sometimes they do if it's going to help with an investigation. And
Okay.
then if they get your contact information, that's great. And then afterwards, they'll just tell you that you can leave.
Okay, oh, that's perfect. You answer my question there. Yeah, that's great.
Yeah,
Thank you.
thank you. Yeah, that's a great question.
I was going to add in something too about the personal belongings. If they end up making it to the hospital, the belongings, and let's say you don't want them with you, or something valuable has been brought with you, let's say a Rolex watch or something, there are provisions in place where the hospital usually has a safe, and security will put those in a vault or a secure location in case something like that does get transferred with you.
Yes. And if you can avoid it, don't take anything valuable that you would be upset if you lost, just in case. Any other questions? All right. Well, if there's nothing else, thank you guys very much for joining us. Ethan, I think that's all that I had. Um,
Okay. Oh, looks like
and
Rosemary, you have something?
maybe a question?
I just saw Rosemary unmute. If not, that's okay. All right. Well,
Okay. All
yeah.
right. Yeah, well, thank you guys very much for joining us. If you do have any other questions afterwards, maybe if you think it could be silly, you don't want to ask it in front of the group, no such thing as a dumb question. Please feel free. Message me, message Ethan directly in the community chat. I would love to answer your questions. And other than that, like I said, thank you guys for joining us. I will be doing another lecture similar to this on another topic to be determined on Friday, and I believe that'll be at 6:30 Eastern Time.
Well, thank you so much, Toby. We really appreciate it.
Absolutely.
Your lectures have been amazing, and we can't wait for your next one. And as always, this one will be able to be rewatched in the classroom section, and we look forward to your next one.
Thank you, Toby.
All right. Yeah, thank you guys.
Good night, everybody. Thank you for being here.
Thank you.
Thank you very
Thanks,
much.
Good night.
Have a good night,
guys.
everybody.
You.
See you next time.
Have a good night.